Hey everyone, welcome back to the Prehospital Paradigm Podcast. I am Dr. John Hill. To my right, I got my normal co-host, Scott Wildenheim.
I usually do this part.
I know.
This is great. Somebody else is taking my job over.
Someone had to work overnight and is a little bit punchy today.
I tell you what, I've been dragging today, so I appreciate you doing it.
But we've got two special guests with us here today. We got Cary and Matt Howlett from, I'll just call you guys from the blood bank. Vicky, you're the manager of transfusion medicine in the blood bank. And then Matt, you're the system QA coordinator for transfusion medicine and blood bank. So welcome. Thanks for coming out and joining us here in a cold November afternoon.
Yeah, hopefully.
No, this is great. Thanks for having us.
Yeah, we like making friends. So
Yeah, sure. Well, I like having you guys as friends because I need what you're selling or providing to me. So we're here to talk about transfusion medicine. What that really kind of means is blood, right? Mm-hmm. Talking about providing blood products to our patients in our community. And really this kind of came up because kind of an ongoing issue with blood and blood products is availability of those blood products. So we're kind of doing this as an obviously for educating our EMS colleagues and kind of getting the word about how important donating that blood is. And then there's been some recent changes in Ohio law in June of 2024. You'll be seeing this in 2025, where they've expanded or added on the ability for paramedics to start blood product transfusions in the field. That was not a skill or competency.
That wasn't part of our scope of practice, yeah.
It wasn't. And in fact, had to be, you guys could transport patients that had blood already
infusing.
Started. Yep. But only a nurse could start the product. Now
initiate the product.
Yep,
Yeah.
Now the initiation has been included to paramedic as an added competency. So thought we'd talk about what that is, and then talk about really the big need for blood. And I think you can't really talk about blood and the need for it and talk about really kind of where it all goes and what that pint that we donate actually becomes. So, again, thanks for joining us. I want to kind of start off with kind of the basics we kind of probably all learned in like some point in like elementary school, middle school, like, oh, we've got different blood types, right?
And have subsequently forgotten.
Yeah.
I hope not.
Mostly.
Yeah, so let's start out with Blood Bank 101, right?
Yeah, exactly.
Let's please start there.
Okay, so we know there's four basic human ABO types. We have O, B, AB, and A. O and A are the majority of patients' types. B and AB are about 20%. So I said most people are going to be type O or type A. We do see a higher increase of patients who are B based on their culture or origin, country of origin. So you'll see more type B patients that are African American in the Asian countries. But yeah, most of the world is type O or type A, so that's good. And then we have the infamous RH type that we can get into a little more. We all hear the term I'm O-pos or A-neg or anything like that. So the question is, what does that neg or pos mean? And so that's the big question.
And its relevance, yeah.
And its relevance to transfusion. So
RH factor is something that we run into a lot with trauma, especially. We're really only concerned about it when it comes to childbearing age females and pediatrics, because that RH factor is something that with blood exposure or even pregnancy you can develop an alloantibody to, something that can be hemolytic and something that can be quite dangerous in the transfusion medicine space. Only about 20% of the population, that's a rough estimate, is RH negative. So the vast majority of the people that we're dealing with, it's not a factor that we have to worry about because RH positive patients can get RH negative, no questions asked. They're not going to make an antibody. It's that reverse that we have
the other way around,
worry about. And then just something that we've been dealing with and kind of the notices that are coming out lately, only 7% of the donors out there are that precious O negative.
Oh, are that negative, yeah.
So that's where our RH factor awareness lives, is where's my donor population and who can I save this blood for or keep it protected to give to.
Yeah, so to expand on that idea of the RH, when we think of red cells, you look under a microscope and you see this like smooth, red, pretty thing. But actually, if you were to really dive down, there's other things stretching out, and those are color antigens. So the red cell has more than one antigen. We have our ABO antigens, our RH antigen, which we like to call anti-D, and then we have hundreds and hundreds of other antigens. Some of them have a function, and some of them we're still trying to figure out. But
They do, yeah.
we do know that the anti-D antigen is what's causing that Rh positive or negative. So when I say you're Rh negative, we're just saying you lack that D antigen on your red cell. And so basic immunology tells us if I don't have something and I'm presented with something,
yeah.
I'm going to make that antibody. So we don't like antibodies. Antibodies are bad. And so we try to avoid making those antibodies. And we know that the D antibody is hyperallogeneic. So there's always a good chance once you get transfused with Rh positive red cells that you're going to make an anti-D. And so that's where we want to avoid that in pregnancy. And that's
But that's only going to be for a patient who's Rh negative who doesn't
correct.
have the D antigen. So if you're
We're
positive,
going to stick with that.
okay.
Cause
Let's not get too far in the weeds.
because there's a whole
There-
podcast
yeah.
just
Yeah.
about people who are Rh positive that are making anti-D. But for the majority
Wow.
of people,
Well-
if you are Rh negative, there's a good chance if you get Rh positive blood that you'll make an anti-D. And
Well-
we don't want to make anti-Ds on pregnant females, and you might be able to explain that a little more.
Well, it turns out that this is so complicated. We have our whole little subsection of medicine just called transfusion medicine because it is so complicated,
Specific to
right?
that, yeah.
So, I mean, but yeah. So the reason for that is when a woman becomes pregnant, and if she is Rh negative, the concern being is that if she gets exposed to any blood that is presenting the D antigen, we call Rh positive, she can actually create antibodies to that, as you just said, and then the problem becomes if the baby's Rh positive, then essentially mom's immune system, because you have another human being growing inside of you, recognizes that as foreign tissue and will
Foreign,
start
yeah.
to attack it. So it will cause mom to lose the pregnancy. That's what we want to absolutely avoid.
And I'm sure we're going to have a ton of comments from OBGYNs being like, that is not it.
No,
But that's okay.
Yeah.
But that's okay.
As
The
a,
broad
as a
brush.
broad brush stroke, yeah.
And that goes for other antigens as well. But we know the D is most common, and so in a pregnant female, we don't want to give her something that's going to attack the baby. And the easiest thing to do is not to give her Rh positive blood in a normal setting,
Correct.
as we just discussed other settings. But in a normal setting, we want to not give a pregnant, childbearing female Rh positive blood.
Yes. So when we talked about blood, and we're talking about really erythrocytes, right?
Mm-hmm.
We're talking about how they present on polysaccharides, all these different antigens. And I think that generally we think of blood as this like red liquid. We primarily think of RBCs or red blood cells on those erythrocytes. Because, in medicine we can't have one word for something. We have to have 45 different words
Yep.
to represent the same thing, but also there's shades of gray when it comes to that. But what else is in blood? So we talk about blood. If I was to cut into bleed, what is that? What's in the blood?
Yeah, so when you are cut, or let's hope that you're donating blood, a whole blood red
Ideally.
cell is
Well played. And
gonna-
nice plug. It's almost
Throw
like
it
you do
out
this
there.
professionally, yeah.
right. I've heard a couple of these podcasts before. So you're donating blood. It gets put in this bag, and it's one big glob of red stuff. So once you've donated, it goes back to the blood center where they will centrifuge it. So they'll centrifuge things down, and they'll be able to separate it out. So when you're centrifuging a whole blood red cell, it can get down into 4 different products. You have your plasma, your platelets, your cryo, and then there's a buffy coat of granulocytes. So we're not going to talk about granulocytes today, but you could do a buffy coat granulocyte transfusion. So our main focus is our red cells, our plasma, and platelets. And then from the plasma, you can make cryoprecipitate. So you can make all these different products. And as we centrifuge them down, separate them out, they all get their own expiration dates. They all get stored differently. And then we can use these in pieces and parts for different patients. So when they say donate blood, you can save 3 to 4 lives. That's what they're meaning.
Sure,
like I can
sure.
use this product on this person, and the other part of that product can go to somebody else.
Yep. And some of that plasma we talk about. A product that you guys have is fresh frozen plasma, which is typically what we talk about when we say plasma. But as you say, we can separate those components out. There's like factor 9, factor 8. We talk about the hemolytic anemias that we use as medicines. We have albumin in there that we use as more of like a volume expansion, which, again, we had a conversation offline of we've got blood, which lives in the transfusion medicine world, but blood's actually a drug, and then we have derivatives of that that are treated like drugs. And I kind of went down this rabbit hole of like, well, yeah, albumin is a blood product, but it's more treated like a drug, and so are some of those all the concentrates out of there. We get 4-factor coagulations out of that we give to help reverse anticoagulation on patients, trauma patients, or if they need to have emergent surgery and they're on a thinner, that we can give those combination drugs derived from blood products to these patients. So it kind of opened my mind a little bit about kind of realizing that we do have a lot of drugs that we derive from these blood products, and why it's so important to
let's tune that. Let's tune that just a little bit more. Again, remembering that the bulk of our viewership or our listenership is, EMS related. And I think oversimplistically, the EMS world is the red stuff, right?
Yeah.
The oxygen carrying red stuff, right? And we almost exclusively think of it, it's, trauma, right? But we see that in the trauma bay. We see that's our biggest exposure to it. So explain a little bit about who gets the other stuff. What sick patients need the platelets? What sick patients need the plasma, and so on and so forth. So just so maybe they can have a better mind model of, I'm taking this patient in, for XYZ. I might not see them get the red stuff in the trauma bay, but they have an understanding that they're still getting a blood product maybe when they get to the unit or something like that. So.
Yeah, so for an otherwise stable patient in a non-trauma setting, red cells are always going to be used to help with the oxygen carrying capacity. Now, some people generally walk around the world with a hemoglobin that might be at a 5 or 6 and they're feeling okay. But then there's other normal people who, at a hemoglobin of 5 or 6, they're a little pale, they're not feeling really good. That's when they're going to show up in your ER, I'm not feeling all great. So even just bumping up their hemoglobin and the oxygen carrying capacity can help them. So that's your normal non-trauma setting for red cell use. Again, mostly in the cancer setting, because that chemotherapy is destroying all those rapidly growing cells. So that's the red cells. Plasma, most of the time in a non-trauma setting, we're really just going to focus on apheresis, I would say, if you look at our plasma usage. So inside of transfusion medicine is a whole world called apheresis. And that's really, we are trying to replace the bad stuff with the good stuff. And we find that there's a lot of plasma containing antibodies that you have. And so we want to get rid of those. And so we will give you nice, clean plasma and get rid of the bad plasma.
Get rid of the bad plasma,
So that's what the plasma's for.
For those who haven't seen it, I think the funniest way to explain it is a human oil change. Like, that's the only way I can sum it up to people who aren't in the medical field, is it's a human oil change.
Yeah. Exactly.
Perfect.
That's great. Yeah.
And then we have the platelets. Again, you're going to see this mostly in a non-trauma type setting in your cancer patients, because the chemotherapy is killing all those rapidly growing cells. So, a person on chemotherapy can walk around with a plate count of 10. I don't recommend they jump into a car or hit a wall or anything, but that's where the bruising and stuff comes in. So platelets are going to be really a cancer patient situation in a non-trauma setting. Again, just making sure that they don't start actively bleeding in some capacity.
Great, perfect.
No, that's what I think this audience, that breakdown is what this audience would appreciate, is that bit.
Yeah, and I think that from a trauma perspective, when we're doing, anytime someone's losing whole blood, right? Because when we bleed, we don't just bleed RBCs. We don't just bleed plasma. We're losing whole blood.
I'm special. I can just bleed plasma. I can just use plasma.
You'll will it, and it will happen.
I think they call it seeping.
You have heart failure? For what we actually do in emergency medicine is we don't actually carry whole blood, right? We don't have whole blood in the hospitals. So for these patients that are coming in hemorrhagic shock, that have lost a large volume of blood, we're going to start with red blood cells, packed RBCs, because most trauma centers, and I have in mine, I've got a fridge that has 2 units of O-type blood that's not cross-matched to anyone, that I can easily pull from to quickly give to my trauma patient, and that's what's going to start the resuscitation of the patient. We just talked earlier, just today actually, about In trauma, the big paradigm shift for me was getting away from large volume fluid resuscitation
Right, yeah.
to low volume fluid resuscitation to a liter, and quickly adding on
Sooner to the
blood products. And so we start with the packed RBCs to start with, because that is the oxygen carrying capacity of the body. But again, you're losing whole bloods, and I don't have whole blood. So what we do is we have our blood suppliers that people donate the blood from, and then we take those parts that they've already separated out, kind of smash them together into what we call a mass transfusion protocol, and get 1-to-1-to-1 typically products that we go, oh, we're going to do red blood cells, we're going to do plasma, then we're going to do platelets, and we're going to start back from the beginning and do that in succession. When we're doing mass transfusion, we also have to worry about electrolyte abnormalities as well, because when we're giving large volumes of these blood products, they come with preservatives in them, right? Calcium citrate's one of the big ones. We have to worry about calcium, and kind of comes into the broader management of these really sick patients when we're talking about using blood products. But for the trauma patients, it really is whole blood, but we're taking those components, putting them back together, and then giving all that volume back to the patients. When we're giving them red blood cells, you mentioned hemoglobin. For those of you that don't know what hemoglobin is, it's typically how we talk about how we measure how much red blood cells you have. There's different when you look at CBC or complete blood count. There are different numbers on there. I'm sure you've all seen them, and they'll say, "Oh, we counted red cells." We measure in hemoglobin. Above 7 is a typical reason where we want you to be, and if you're below that, we do typically transfuse. There's reasons to adjust that number up and down for certain reasons. But typical ranges are going to be 12 to 16 off the top of my head, not counting for lab discrepancies, right?
Right.
But
You mean every lab doesn't report exactly the same thing?
interestingly enough,
It's more the draw that comes from the floor. Just saying.
I am staying out of this fight.
But in all seriousness, I mean, that's some of the stuff we from a hospital side of things, we take for granted. We know that there's little variances in these things, and why are you standing there reading that? Because you have to understand the parameters from which they were drawn, or how they were tested, I should say. So
I bring up hemoglobin because if we're doing packed red blood cells, if they're getting what we call a unit of red blood cells, which is 350 mLs, give or take, we expect your hemoglobin, which is measured in grams per deciliter, to go up by 1. Makes it really easy for the dummy yard doctor to be like, okay, they're at 6, I want to get them to 7. 1. Perfect. What's interesting, though, is we talk about not acute hemorrhagic blood loss. If you bleed out whole blood, if you come to my trauma bay and I measure your blood, you lost whole blood, I'm going to measure your hemoglobin. It might be 12, but you're tachycardic, hypotensive.
Yep.
I have
Pale,
signs that you've lost 50 to 70% of your blood volume. I measure your hemoglobin, it's going to be 12.
Yeah.
That's because you've lost whole blood. I know that that's not a real number if you were volume expanded. So what I need to do is still give you that blood. You need blood
adjusted for the scenario. Yeah.
So I want to just bring that up in the context of mass transfusion, putting these components back together.
Oh, no, sure. Because, I mean, when we think MTP, you're not going to be looking at, you as the physician is going to be like, well, the hemoglobin's this right now, so I should give 2 or 3 of these. You're like, no, my patient is bleeding out. Yeah. These numbers are not reliable. I can see that this much volume has gone out, and I need to replace that with something that mimics a whole blood type setting, and that's where the red cells, plasma, platelets come in on that situation.
Yeah.
So the lab results aren't necessarily reflecting what is actually going on.
We talk about a lot in this podcast. One of our reoccurring themes is don't treat the numbers, treat the patient.
Yeah. I like that.
So if the numbers don't match what the patient's presenting with, have the understanding to just treat that patient, not the numbers, and that's a better way to just take care of your patients.
Yeah, the story. And the other recurring theme is, the story tells all, right? Yeah. Tell me about how much was lost on scene. Tell me about, right, the objective things that we can look at a patient and say, oh, okay, we can estimate their percentage of volume loss.
Yep. So we talked about red blood cells, and they're through all the oxygen carrying capacity of the majority of the oxygen carrying capacity, if we want to be specific, because we can dissolve oxygen in plasma and in water, essentially. Plasma carries all the clotting factors, right? So we talk about clotting cascade. There's intrinsic and extrinsic, and then we've got platelets. So platelets put the mesh to start to cover up the hole, and then the coagulation cascade comes in from the intrinsic pathway, binds to that to really kind
reinforces
of
it, yeah.
reinforce that clot. And then in the pre-hospital setting, and probably you guys too, we talk about using TXA to help stabilize those clots. And so for our bleeding trauma patients, or our bleeding patients in general, whether it's more classically like OB patients, I feel in my experience has been OB kind of really led the charge with using TXA.
TXA for sure, absolutely.
So, my point to bring this up is for our EMS colleagues, like this is all kind of really kind of tied together, in how we take care of our patients from the blood bank for trauma to OB. It gets kind of into the weeds when we're talking about coagulation cascade, and I have to study it myself to be able to answer test questions about it.
It's definitely one of those things you remember for the exam, and once the exam's over, it's not as important. I can Google that.
Yeah,
right,
exactly.
Yeah. I understand the macro concept. The micro concepts, I'm a little fuzzy on sometimes, right?
Well, there's lots of memes out there, and like my patient's not going to have a bad outcome because I don't remember the coagulation cascade from top to bottom.
Yeah.
They're going to die because I didn't give TXA, or I didn't give them plasma because they needed all the factors in there to help them stop bleeding. Like I need to know the actual functional
life-saving,
medicine.
functional medicine.
Yeah.
Well, yeah, that's exactly what. Well, that's what we do in emergency medicine.
Yeah. All right. So we talked about the different blood types: A, B, O, and then we talked about RH factor, and that's how we get the typical A positive, B positive. Let's talk about when a patient comes in, and we talked about more controlled scenarios, or even mass transfusion. If I'm giving blood to these trauma patients, I'm going to give them this O blood because I know statistically it's going to be okay that they're going to receive this initial blood product.
That was a little on the nose, wasn't it?
But, nothing in medicine or life is 100%, right?
Of course not, right?
Especially transfusion medicine.
Exactly.
Yeah.
So let's break it down. What are we going to do with the patient? What is the best compatible units for a patient? So we know the 4 ABOs. Now there's a front and a back. We know what's on their antigens, and we know what antibodies we make, and that's how we determine what is compatible with your patient. So in the world of medicine, a type O patient will lack 0 antigens, and they will have antibodies to A and B. So a type O patient can only get O red cells because you don't want to give them antibodies to things that they don't have.
Right.
But on the back side, we know that A, B, and AB patients have antigens to A, B, and AB. And then on the back end, an A person is going to have antibodies to B, an AB person is going to have no antibodies because they have the antigens, and so forth. So based on this magical blood bank test tube thing, we've determined that anybody can get type O red cells, provided there's that 30% chance that there might be some other antigen antibody scenarios, but another day, right?
Yes.
So we're
Unless
going
you
to
want to talk about Bombay, but that's a whole other
Oh,
conversation.
please no.
Oh.
That's a nightmare. I've only seen one ever. You don't want to see it.
Yeah. So in the world, when we're just saying what ABO type can I give my patient, we're going to give type O if we don't know what your ABO type is. Because we want to try to be good stewards of the product, so if we do know your type, then we want to give you type specific or compatible. But in an emergency, unknown, just walked in the door, just got dropped off in your ED, what am I going to give them? I'm going to give them group O. And then we have to talk about the plasma part. So based on the same concept of front type, back type, we would want to give everybody AB plasma because you can't make an antibody to something that's not in the plasma. But there's not a lot of people who are AB. So most of our population is A and O, and then we start dwindling down the Bs and the ABs. So then, after wonderful studies in the DOD, we've determined that in a bleeding patient, you can give type A plasma. So that's what we do for adults. So there's a lot of, what do I give and it's really dependent on, is the person actively bleeding? And is this an adult or a pediatric patient? Because then we get into the size of the patient as to whether or not it's acceptable to give that kind of a product. So there's a lot of questions that need to be answered when that patient is in the ED before we can decide what the best product is.
And that's happening concomitantly with I'm giving that group O product while we're sending off blood to the lab, multiple vials to go through. Why don't you talk about cross-typing and cross-matching a little bit? Just because people hear those
terms,
so that what they actually mean.
So when we get that sample, you guys are sending us a type and screen.
Yes.
So the type is the blood type, like Vicky was talking about, and the screen is that initial antibody testing. So if the patient hasn't been transfused, hasn't been pregnant, 99% of the time we're not going to have an issue with that popping positive. You have some of those naturally occurring ones, but it's not the common thing that we're going to see. You give us a second ABO as well, because what we want to do, especially in those heated situations, is make sure that you actually sent us blood and labeled it in the heat of the moment from the right patient.
Same patient, yeah, right.
Yeah, we've seen the news reports from elsewhere in the country where they got one sample, switched to type specific on that patient, surprise it wasn't them, and it turns into a nightmare scenario.
Turns to badness and
yeah. So we're doing those two types on two separate samples collected at two separate times. That's how we want you to step away from the patient, step back, re-identify them, draw us that second sample.
Come back.
And then
Safety
we're doing
net,
yeah, for sure.
Yeah.
Especially because of just how dangerous blood can be if it's misused.
Sure.
And then that antibody screen. So those are our big two. Once you get into cross-matching, so you need 5 units on your patient right away. The only product that we're actually cross-matching are the red cells. The plasma and the platelets just get assigned to the patient based on the types we have on file. The cross-match itself, we have a couple different iterations of. If a patient's come in and they have a negative antibody screen, they haven't made any antibodies, we don't have a history of them having any antibodies, at least where we're located at CMC, we have access to an electronic cross-match. So we have a truth table built in our computer system that when we scan in units, the tech still has to pick them and pick appropriately. But we have a table that double checks that selection and says, nope, everything is acceptable, this is good to go, or try again, you picked the wrong thing.
Still wrong.
Yeah, try again. We have a couple populations that we exclude from that. Patients who might need some additional antigens tested, mostly are sickle cell patients or patients who've had bone marrow transplants, anybody who might have a discrepancy, something doesn't quite look right. We're going to do a serologic cross-match. We're going to take that patient's plasma that would contain the actual antibodies that are floating around in their body and run it against a sample of the red cells from that donor unit and see if there's a reaction. Patients who have known antibodies, it turns into a much longer process where we have to screen units, identify them, and then there's a AHG, anti-human globulin, or a IgG cross-match, where we're incubating it, spinning it for a longer amount of time, just trying to see if a reaction's there to give you that safest product possible. I think Vicky and I'll probably both say it a couple times. It's always about picking the best product for your patient at that time. And
generally that's going to be a type-specific product for you.
Yeah, we like to switch you to type-specific as fast as possible, especially with how busy our facility is. We want to save those O's.
Sure.